questions about whether this will be recorded or is being recorded and whether the recording will be available. And I can confirm that it is being recorded and it'll be available. Moving on now to our final speaker, Dr. Amanda Punyawan, who's be speaking on whose title is A Bad Tooth or a Sad Tooth. Bit of a tongue twister there, Amanda. Amanda is an oral medicine specialist in Perth, Western Australia. She works in private practice and has a public appointment at the Oral Health Centre of Western Australia. Her research interests include the use of visual illusions in burning mouth syndrome patients, temporomandibular joint disorders, oral mucosal disease, dental sleep medicine, and pediatric oral medicine. She's the editor and examiner for the Royal Australasian College of Dental Surgeons, treasurer of the Australian Dental Association, the West Australian branch, and is heavily involved with various professional committees. She's passionate about her specialty, regularly lecturing and running oral medicine interest pages and dental forums, as well as teaching at the University of Western Australia. Over to you, Amanda.
Thank you very much. So I'll give it a go at trying to run the screen. I think there may be a slight delay, so if everyone can just bear with me while I click that. There we go. So I thought I would introduce oral medicine in case some of our listeners were not aware of what oral medicine actually is. So it is a dental specialty, and we see medically complex patients, oral mucosal disease like white patches, red patches, oral cancer, potentially malignant disease, dental sleep medicine, radiographic findings, and of course, temporomandibular joint disorders and headaches. One of my favorite things about oral medicine is that we're quite a tight-knit community worldwide, and I had a quick look through the list of participants before, and I saw some familiar names there. So thank you everyone for joining us. So I would like to start off the presentation by telling you about Debbie, who was one of my patients. She is a 17-year-old female who was referred for orofacial pain in the head and neck region. Her father came to the appointment with her. Now, her medical history was significant for type 2 diabetes, for which she was taking metformin, obesity, for which she was taking phentermine, and she was under investigation for pelvic pain. She is a never smoker, doesn't consume any alcohol. When I was taking a psychosocial, I skipped forward one. I don't know how I can go back. But when I was taking the psychosocial history, there was nothing significant disclosed. However, from her body language, I could tell that there was something a little bit more. So I asked her father to wait in the waiting room. And it was then that she disclosed sexual abuse by her father's friend when she was 14. She also told me that her parents were aware of the situation. The case was reported to the authorities. However, there was no outcome. Now, this patient's name was Debbie, but it could have been Susan, it could have been Sharon, it could have been Mariam, it could have been David, it could have been Michael, it could have been Anthony. My point is that if you are treating chronic pain patients, this is one of your patients, because her case, sadly, is not unusual. So let's explore some of the how, what, and why behind childhood adversity and the impact on orofacial pain. So the first question is, how common are these adverse childhood experiences? To answer that question, one of the big landmark studies in the area is the ACE study, and they looked at almost 17,000 patients. What ACE? There we go. So I actually found these statistics very shocking. So 1 in 7 people would have experienced child neglect or abuse. So there were over 1,000 people who registered for this webinar. To put that into context, about 150 of those people would have experienced child neglect or abuse. And this number is also likely to be an underrepresentation. The other interesting thing that came up from the ACE study is that this does not necessarily affect who you think it does. So when I tell you about people who have experienced child neglect and abuse, you might be thinking of the financially unstable, the ethnic, or the uneducated. The ACE study, the average age of their patients was 57 years old, 80% were Caucasian, most were middle class, and 75% were college educated. So this is you or me, this is our colleagues, this is our friends, this is our community. Sorry, I think it's frozen. There we go. So the ACE study had 10 questions, and it was broken down into abuse, neglect, and household dysfunction. So hopefully everyone who is listening at the moment has a pen or paper where they were taking down questions. And as we go through these 10 questions, give yourself 1 point if your answer is yes. So prior to your 18th birthday, did a parent or other adult in the household often or very often swear at you, insult you, put you down, or humiliate you, or act in a way that made you afraid that you may be physically hurt? Did a parent or other adult in the household often or very often push, grab, slap, or throw something at you, or ever hit you so hard that you had marks or were injured? Did an adult or person at least 5 years older than you ever touch or fondle you, or have you touch their body in a sexual way, or attempt or actually have oral, anal, or vaginal intercourse with you? Did you often or very often feel that no one in your family loved you, or thought you were important or special, or your family didn't look out for each other, feel close to each other, or support each other? Did you often or very often feel that you didn't have enough to eat, had to wear dirty clothes, and had no one to protect you, or your parents were too drunk or high to take care of you or take you to the doctor if you needed it? Were your parents ever separated or divorced? Was your mother or stepmother often or very often pushed, grabbed, slapped, or had something thrown at her? Or sometimes often or very often kicked, bitten, hit with a fist, or hit with something hard, or ever repeatedly hit over at least a few minutes or threatened with a gun or knife? Did you ever live with anyone who was a problem drinker or alcoholic, or use street drugs? Was a household member depressed or mentally ill, or did a household member attempt suicide? Did a household member go to prison? Now add up your yes answers, and this is your ACE score. So ACEs are unfortunately common. You can see here that out of the ACE study, 26% had 1 ACE and 12.5% had 4 or more. Now this is out of the scope of this lecture, but if you have an ACE score of 4 or more, you are at significantly higher risk of many mental health and bodily health conditions. Now, in the context of orofacial pain, how is childhood adversity actually associated? Does childhood adversity accumulate and prime an individual to be vulnerable later in life? Or could early life adversity set an individual off on an unfavorable life trajectory from which they accumulate and develop susceptibilities to certain pain conditions? Could there be a biological programming effect where childhood adversity could lead a child to be less able to cope with later life stresses? Or could a history of adversity increase vulnerability to emotional distress and increase the tendency to attend, amplify, or overinterpret somatic symptoms? Well, unfortunately, 1 + 1 does not equal 2 in this case. The connection of the type of adversity to clinical and psychosocial variables does remain unclear. And similarly, there is an unclear relationship between when the adversity occurs and if or when chronic pain will manifest. So it's a little bit of a chicken and egg situation as well. Does the pain actually drive the psychological symptoms or vice versa? And I will put to you in this case, does it really matter? Well, that's a bit frustrating, you might be thinking. So why don't we know more? Well, simply put, this is very hard to study. There are inherent difficulties in looking at these patients. The very nature of chronic pain is insidious. There is often not a specific time of disease onset, and we may not have independent confirmation of these adverse childhood exposures. And in the people who report them, there may be a recall bias. While there are many unknowns, it is clear that associations have been found between childhood adversity and chronic pain states, including fibromyalgia, headache, migraine, irritable bowel syndrome, interstitial cystitis, endometriosis, vulvodynia, chronic pelvic pain, PTSD, systemic assertion intolerance disease, and temporomandibular joint disorders. Both Tara and Olga have talked on these comorbid conditions as well. So when looking at the literature specifically for temporomandibular joint disorders, this study from 1997 looked at 58 female TMD subjects, and they had 39 age-matched controls. A greater percentage of TMD subjects reported a history of physical abuse. This was greater, but not statistically significant. They found that the prevalence of sexual abuse among TMD subjects to be similar to that of other chronic pain populations. And there was a higher proportion of patients with temporomandibular disorders who disclosed a history of sexual or physical abuse. This study in 2000 looked at 114 women with TMD. Sorry, I've lost that slide, but let me just tell you what it said. So that study looked at 114 women with TMD, and among those with a history of physical abuse, those with a history of physical abuse reported significantly more pain than those who reported a history of sexual abuse or no abuse at all. So this study was interesting because they didn't find that people who were sexually abused were more prevalent in the population with TMD. Now, this study by Riley et al. In 1998 looked at 139 patients, subjects with TMD. And this is really significant. 49% of them had a history of physical and/or sexual abuse. That's almost 50%. And the abused subjects reported significantly higher levels of anxiety, depression, and somatic symptoms than non-abused subjects. This study looked at 2,000 11-year-old children and followed them up for 3 years. And they wanted to find out if there were predictors in early adolescence that were associated with the development of clinically significant TMD pain. They found that female gender, somatization, the number of pain complaints, and life dissatisfaction was significant. Surprisingly, they didn't find that depression was an independent variable in this study, although we know from some of the other studies that were cited earlier this evening that it is in adults. This was a big study where they looked at the mothers of over 12,000 children, and they followed them up for 31 years. And they found that parental depression during the offspring's childhood was significantly associated with facial pain and TMJ pain at rest. This was not found in the offspring of antenatally depressed mothers. And this study really highlighted the importance of effective treatment of parental depression. So in summary, looking at the studies, these are the childhood risk associations for temporomandibular disorders. Female gender, which Olga touched on, somatization, life dissatisfaction, history of physical abuse, possibly a history of sexual abuse, and parental depression during childhood. So hopefully the presentation today has underscored how important it is to be taking a good psychosocial history. Now, for someone who may not be routinely doing this or may be new to doing this, I can understand that it can be very confronting. So the photograph that you see there on the top left is actually from a patient of mine. I think one of the things when taking social history is to be aware of certain red flags that may clue you into the fact that you should be asking more questions or the patient may need a little bit more TLC. So this patient had brought in an entire box of splints that she had tried and none of them had provided her any relief. Now, if you are treating your patient and things are not going the way you expect, it's always a good idea to go back to baseline and reevaluate and see if you've missed anything. In the case of Debbie, which we discussed at the start of this presentation, I asked her father to wait in the waiting room so she would be more comfortable disclosing history to me. I'm not saying that that's the case for every patient, but sometimes you might find that it might be easier to talk to them alone. So if you don't have your assistant or other family members and the door is closed, then there are not too many people in the waiting room that can overhear. One of the components, I think, for taking a good psychosocial history is also following your gut and involving the team. So if you've got consent from the patient, involving their other health practitioners in their care may not be a bad idea because you may find out something that has not been disclosed, and it might also clue you in to involve other team members for multidisciplinary treatment. I know this might sound a little bit trite, but I think there's not a lot in life that can't be accomplished with small, little achievable steps. So if you're not asking the patient these questions for their psychosocial history, why not start tomorrow? So you can pick a patient, any patient, and just ask them how they are going, how their life is, if there is any reason that they can think of why they may not be getting better. So in the words of Nike, it's not my shoe there, but in the words of Nike, just do it. Now, one of the things, so if all else fails, I think it's great to remember your prognosis, why you are doing this. Because finding out the patient's psychosocial history affects their prognosis. It helps your treatment planning. It can clue you in to involve other professionals or teams. And at the end of the day, we have to treat our patients holistically. Like, the patient's pain is more than a joint pain or more than a headache. We care for our patients. So this should be something that's very relevant for us. And to go back to the topic of today's webinar, which is, can we prevent orofacial pain? Now, as I've underscored, the association between childhood adversity and orofacial pain is muddy at the moment. We know that this association, we don't know how it happens and what the clear relationship really is. But if we can prevent childhood adversity in our pediatric patients, that can only be a good thing. So take-home messages is awareness of chronic pain states and comorbid pain conditions, the importance of psychosocial factors. Taking a pain history should include consideration of sociocultural features, and practice makes perfect. This underscores the importance of the biopsychosocial model of management, which is often multidisciplinary. So you may have noticed as we were going through the presentation that I have a few children's drawings in there. Now, this is actually from the special interest group Pain in Childhood from the Portuguese Association for the Study of Pain from last year's global year, which was looking at vulnerable populations. And these drawings were from the exhibition called Drawings of My Pain, and it had a very significant impact on me. So I hope you found them not inspiring, but I hope they impacted you too. So I would like to thank everyone for listening. This is an area that I find very interesting, and I'm hoping to conduct more research in the area. Thank you to Ramesh, who kindly accepted the invitation to moderate, and also to the speakers, Tara and Olga, and most of all, to the listeners, IASP and Jeanette. If anybody has any questions, feel free to contact me. If we couldn't answer all of your questions, you can find me on Facebook or Instagram. Thank you.
Thank you, Amanda, for a wonderful presentation. Now, can I please get all the panelists to unmute so we can start taking some of these questions? As I was saying before, there are a fair few questions that have come in. So I'm going to, I guess, pick and choose, and so that the attendees are aware we are over time, but we're going to go on for a bit longer. So if you're unable to hang around, you can perhaps watch it at a later time. So I'm gonna get started with some of these questions. I'm not going to identify the question where the questions have come from. Rather than I'll pick the panelists that I believe would be most suited to answering this particular question. Olga, would you like to take this question, please? So this question, and I might paraphrase a little bit, when we try to make a pain model in animals, how much do we mimic? And it goes on to say, do you think it is representative of an orofacial neuropathic pain in humans? So basically implying when you try and do a pain model in animals, whether this is any representation of the neuropathic pains that we see in humans. Are you happy to take that, Olga?
Sure. So we have to keep in mind that animal models of nociception have two important components. Number one is the method of insult, and the second one is the subsequent endpoint measurements, right? So there are two elements, and translation of animal models from the lab to the clinic has been limited, with inflammatory pain models being more representative of the clinical representations of pain, but yet not perfect. And also, we come to pain measurements. Most of the pain measurements in rats are done on the evoked response to the stimulus. It's not necessarily reflective of spontaneous pain that we see in clinical setting. So it's difficult to, and efforts has been taken to develop methods that record the spontaneous pain in animals, but it's still hard to determine like what is really pain, right? So animals can't give us on a scale from 0 to 10, show me how much pain you're in. It's more of the response to the evoked stimulus. Also, the drug testing that was done in the animal models don't necessarily always translate to the clinic. But again, these animal models are crucial in our understanding of mechanisms involved in different molecular pain models. And ideally, if we could use maybe other animals that are closer to us, like, primates, which is most likely never happen, but they would give us a better understanding of, and probably we would mimic those animal models more closely to reflect the pain that we see in it. I hope that answers the question.
Thank you, Olga. Tara, are you there?
Yes, I'm here.
Thank you. Tara, can you suggest an economical chairside test for neuropathic pain?
College forceps and history. So,
Thank you.
So basically history, the history has to fit, as I've mentioned several times. Chronology, the onset of the event has to happen around, we're talking specifically about post-traumatic neuropathic pain, then it's a surgical or some kind of intervention, injection, dermablation, lip fillers, whatever may have caused the tissue damage. And in most of the traumatic events, the neuropathic pain starts at that event. The only ones that have delay, and if you look to I've often questioned the diagnostic criteria, we still have a 3-6 month window of onset, but that's to include chemotherapy and radiotherapy and drug-induced peripheral neuropathies. So traumatic neuropathy usually is of immediate onset, with the exception of endodontics, where you may have a 2 to 3 delay, which I believe is due to the chemicals leaching out of the apex into the IDC, causing a delayed onset neuropathy. But otherwise, it's immediate onset. And then basically you map out a neuropathic area. You can do it with a cocktail stick. You don't even need dental instruments and a tissue. So you just map out the area. It has to be obviously within the dermatome of the treatment. So if you did an implant in the left mandible and the patient's complaining of numbness in their forehead, you're off the hook. So you map out the neuropathic area and then test that neuropathic area. If they have pain to the to touch, or pain to cold, or pain to hot, that proves that they have allodynia. If they have increased pain to sharp blunt, then your sharp stimulation, or cold or hot. Heat pain, then they're going to have hyperalgesia, thermal mechanical hyperalgesia. And if they have a reduced response, then they've either got total anesthesia or they've more likely got hypoesthesia.
Thank you. Since you're on a roll, can I ask you, because there's a follow-on from that, what's your opinion on pre-surgical pharmacological treatments to prevent post-traumatic?
That's a good question. There's been some work around looking at tricyclic antidepressants, so amitriptyline, nortriptyline, and also the gabanoids, so pregabalin, gabapentin, looking at preloading the patients at high risk, particularly those patients talked about perhaps having limb amputation pain, so preventing limb amputation pain post-breast surgery, post-thoracotomy. And the evidence is not great. Probably the strongest evidence is actually using local anesthetic where possible, even in an anesthetized patient, to maximize that afferent barrage intraoperatively.
Thank you. Amanda, question for you. With regards to asking patients about childhood, the influence of childhood trauma and its effects. So are you suggesting a direct question to an individual about childhood trauma, or is this do you recommend instituting the ACE questionnaire?
You can. What I do for my patients is that I ask, so first when they present to the clinic, we ask them we get them to fill in a questionnaire, and that has an amalgamation of, for example, some of the questionnaires from the DCTMD, some of the things that we want to know. So we have some things that are written. So that will cover some of the psychosocial history. As to whether I think everybody should be asking all of their patients whether they have ever had a history of abuse, I think that's a little bit of a dicey one. I think it will be good to use your clinical judgment to see if the patient will be receptive to that. I think as far as possible, finding out if any of these are playing a role in the patient's presentation would be ideal. But one of the common comments that I get put to me from some of the people that I teach is that, especially if it's a male clinician asking a female patient or even a younger female patient, they can feel very uncomfortable. I think my response to this is that if you are feeling very uncomfortable with it, then maybe practice it, take it in steps. I think if you feel overly awkward, the patient will pick up on that too. But I'm actually very interested to find out, for example, what Tara does, because I know she's mentioned that she's put it into a questionnaire. So do you screen every patient for this,
Yeah,
Tara?
we do, Amanda. So I'm really lucky. We have this system called IMPARTS, which is set up by the Institute of Psychiatry Psychology, which happens to be just opposite the hospital where I work. Set up by a senior psychiatrist, Matthew Hoptoff, and they started screening all patients in the whole of the attending all of the hospital, King's College Hospital, patients and carers, just looking at basic anxiety, depression levels, and then that led into evolving specific clinicians who wanted to screen their patients. And so my patients we follow, like you, the DCTMD, but we don't have the jaw function. We've left out a few bits, but we have the PHQ-4, PHQ-9, PHQ-15, we have the global chronic pain scale, we have the BPI facial pain, we have catastrophizing score, PCS. We also look at, what else do we look at? We look at post-PTSD, and we look at pain detectors, a neuropathic modified one for orofacial pain, neuropathic pain. But actually on top of that, we do a very basic 5-question sleep questionnaire. And we also use the SPAC, so the Sexual and Physical Abuse Questionnaire. But the important thing about these questionnaires is they're all done on a tablet form by the patient when they arrive in the waiting room. So it's done very independently in their own time. And then that's automatically uploaded onto my electronic patient record. I am so lucky. So we actually have that with all the red flags screened up if they have high anxiety, high depression, somatic disorder, whatever the problem is, with recommended treatment. So we've actually scripted in, urgent referral to psychiatrist, urgent referral to IAP services, which is our local, or GP, general medical practitioner. So we have all that inbuilt in the system. And I cannot tell you, it's been incredibly well received by patients, because it gives them an opportunity for the first time sometimes to actually talk about stuff. I also routinely ask about significant life events that happened around the onset of the facial pain, but also I ask about previous significant life events, particularly if they have a profile that's worrying or based on that screening. So it's revolutionized my patient care. We are in the process of actually enabling that system. So my patients can now do that. I haven't done it yet because obviously I haven't seen my pain patients for a while. But we are now in a position where we can actually get those patients screened before they even come into hospital. And on the basis of that, I'm hoping that we may be able to build an app that will be available for chronic orofacial pain clinicians or dentists or whoever, varying scales from very simple few anxiety, depression screening through to more complex orofacial pain patients. How we grasp the results, harness the results of that, I'm not quite sure, but the app is actually about halfway through development at the moment. So I think it's absolutely, I feel for the first time in my life, and Ramesh has had me say this just recently in March in Sydney, I feel like I'm actually treating the whole patient for the first time in my life. I'm not just treating their face. Does that make sense?
Yes, it does actually. Yes. Yeah, thank you for that. Someone's commented that they can't wait for the app. I can't wait either. That'd be great.
Well, it'll be simple to begin with, but we'll build on it. We're trialing it we've got an Orofacial Pain Alliance nationally, so we're just about to trial it with the group nationally. We'll see how it goes.
Fantastic. Olga, a question for you, if that's okay?
Sure.
It started with a compliment, excellent presentation, thanks. Just wanted to know if there are any diagnostic procedures being used in the diagnosis of orofacial pain other than imaging and nerve blocks. So any other diagnostic procedures that you feel may be useful apart from imaging and nerve blocks?
So I think mainly history and symptom based. So in certain cases, imaging blocks, neurological exam, including QSTs. Certain orofacial pains and other pains have specific blood tests, for example, temporal arteritis. And this this is the aim for the future for diagnostic biological marker axes, that if we could develop something that, I came across an article that said that they had a panel of 72 polymorphisms that they could map people at the risk of pain, but I don't think we are there yet, but it's definitely for the future.
Great, thank you. And just to follow up on that, do you find the carrying out a QST as part of the history and examination process, well, in this case, the examination process changes your treatment plan in any way?
Does QST change the treatment plan?
For neuropathic pains.
For neuropathic pain.
So can I interject there?
Sure.
Please.
Yeah, I don't want to. Olga, are you happy? I feel I can sort of address this because essentially it's really interesting. Obviously, the QST for neuropathic pain was again derived by Ralph Baron's German neuropathic network team. And it involves, I think, a minimum of 11 criteria. And when Peter Svensson and Mark Drangsholt and others tried to apply this to their orofacial pain patients, it was taking like 3 hours per patient. So the full QST protocol is not appropriate for even research patients. Now, Jaskalinen has talked about where QST may be indicated. So if you look at the diagnostic criteria and the Nana Finnerup I mentioned about grading neuropathic pain, then technically in the limbs, they will go as far as doing not just qualitative sensory testing, but they will go as far as doing QST to have a definite diagnosis of neuropathic pain, along with many neurologists do a biopsy, a skin biopsy as well. But I wrote a paper, a review with Maria Devine, Justin Durham, and Don Nixdorf, which I think was published 2 years ago. And we looked at the diagnostic criteria for orofacial neuropathic pain. And we felt actually just the QST, just confirming that you have the chronology of the traumatic event and the qualitative sensory testing with a neuropathic area that may be hyperesthetic or hypoesthetic with positive or negative signs, that was probably sufficient to qualify that was a definite neuropathic pain in that patient. But the other question is, just Carlin, and obviously with the new diagnostic criteria I call the burning mouth syndrome, which some people would say, is it neuropathic pain or is it nosoplastic pain or is it both? Just Carlin, then based on her recommendations, we now have to do a qualitative sensory testing minimum or probably QST in burning mouth patients to decide those that don't and do and don't have somatosensory changes. So that's where the QST definitely has a role in diagnosis of patients.
Thank you, Tara. That was interesting. Amanda, can I get you to take this question, please? What sort of areas do you typically cover when asking a psychosocial background in a new patient? Do you cover things like job, stress, family? Could you please let us know? I guess this is in an informal history type approach rather than in a questionnaire.
Yeah, so it is fairly. Oops, sorry. Can you hear me? I put my mic up. Yeah. So it is fairly. Thank you. So it is fairly extensive. What I like to ask is sleep. How many hours they sleep at night? Are they sleepy during the day? Do they have any trouble falling or staying asleep? I'd like to know about their diet, alcohol, tobacco, drugs, caffeine. When it comes to their pain, the effect of pain on their daily life. Does their pain prevent them from working? If there's any sort of insurance claim, financial stress, as Tara said, any sort of issue happening around the onset of the pain. You'd be surprised. I had so many people undergoing legal troubles, being sued at the time when the pain began, deaths in the family, who they live with at home, their support system, who they're with. It's fairly extensive. I mean, what might actually be better in the interest of time is maybe, Jeanette, I don't know if we can do this, but I'm actually happy to send out some resources to people that are interested about the type of things that we ask. The other alternative is to look at the DC TMD, because a lot of the questions are on there as well. And yeah, I think that might probably be easier than me going through everything.
Yeah, so I'll just interject here. So we'll send a follow-up email to everybody that's either attended or signed up with a bunch of resources, and all the slides or the recording and a whole bunch of different things through IASP or through any of the resources our panelists have mentioned. And then if our panelists are interested, I can also just send all of the questions, and then you can write the answers, and we can also post that on our website, since I know now it's about a half hour over our time, which is wonderful. But I know a lot of people have had to leave in that time frame. So I think that would probably be our best bet going forward. That way everybody can get all the information and you all can have a little more time to answer the questions or provide other resources as well.
Thank you.
Yes, sounds good.
Thank you.
Yeah. Can I finish off with a question that Tara, if you don't mind answering this question, because I've had multiple questions on this one theme. I guess I'm going to try and tie 2 or 3 questions into one. In the case of PTTN, so caused by an implant, how and when do you decide whether to remove it? Could the removal cause further damage? And then there's also questions about, do you remove the implant at 24 hours post-op if neuropathic signs and symptoms are apparent? I think this is something that even I, even this week, faced. The implants right over the canal. Clearly, patient has neuropathic pain and associated signs and symptoms. Would removing it cause more damage? Should this have been removed to the 24-hour mark? Do you mind commenting on that, please?
Thank you, Ramesh. So essentially, you have probably 24, 30 hours to get it out. After that, there's no point doing it. I keep trying to remind clinicians that actually the patient's more important than the implant, which I think a lot of implantologists struggle with. They're very precious about their implants. So the patient's more important than the implant. If a patient reports, or you phone them up, hopefully, proactively, the following day after surgery and after local anaesthetic, they have persistent pain, you get them back, you check that they have a neuropathic area in the lip and the gingival region, either with positive signs. If they're hypoaesthetic or numb, you can discuss with the patient whether they want to leave it like that. It's very likely that they're going to get worse based on the 1,331 patients we've analysed. They're more likely going to stay the same. But if they have pain, they probably it's not going to go away. It's going to be permanent. So you need to get the implant out. Does the removal of the implant cause more damage to the nerve? No, I think the maximum damage has been done to the nerve already by the implant prep drill. But by removing the implant, hopefully you're actually minimizing the continued inflammation and possible bleeding in the area and primary and secondary ischemia, which is probably causing ongoing nerve injury. It just takes 6 hours, causing primary or secondary ischemia around a rat inferior alveolar nerve. 6 hours, you get a permanent degree of damage in that nerve. So it doesn't take long for the permanent ischemia, to cause permanent neuropathic damage in the nerve. So if the patient has a very small neuropathic area with hypoesthesia, you would discuss with the patient whether they want to leave it in. But if they have a large neuropathic area and they have pain, or a moderate to large neuropathic area with pain, or even a small neuropathic area with pain, I suspect the patient will want you to get it out. So get it out and review the patient.
And what if it's been a few weeks or a couple of months?
Treat them as a chronic orofacial pain patient. They won't be happy.
Leave the implant.
Yeah.
And you leave the implant as is.
Yeah, there's no point doing anything.
All right. Thank you, Tara.
Unfortunately, yeah.
Yes. Thank you. Well, I'd like to take this opportunity to thank all 3 speakers. Thank you, Tara. Thank you, Olga. Thank you, Amanda. Apologies to there's dozens of questions that keep coming in. We can only get through so much, but hopefully the ISP can facilitate on getting some of this information out to you promptly. So over to you now, Jeanette. You there?
Sure, yes, I'd just like to thank everyone for attending, and I will say that we will hopefully be able to answer all these questions and post them online. We have our whole Global Year webpage, so I hope that people will also visit that. And if you are not members, I hope you will also become members. We have a special interest group related to orofacial pain, so I think that might be of interest to a lot of people on this webinar, and all of that information will be in our follow-up email. If anybody does have any questions, we're all available, and you can find all of our contact information on the IASP website for IASP staff. And I really just appreciate everyone coming and sticking with us for the extra time and all of your questions and just all of your engagement. I hope everyone has a great day.
Thank you.
Thank you. Bye-bye.
Bye.
Thank you. Bye.